Can you hear me, Dr. Nee?
Yes, I can hear you. Can you hear me?
Yeah, let's see. Do we have our quorum here?
Hello, Doctor. Um, we are sorry. This is Kelly Sheets with DMS.
Hi,
We
Kelly.
we do not currently have a quorum. I hope you all can hear me. I don't have much of a voice, so
We do.
okay, good, good. Right now, I just have you, Dr. Thornberry, and Dr. Neal. If I've missed anybody, please speak up. But I don't believe I have.
Well, the ox is slow, but the earth is patient. We will be a little patient.
All right.
I hope everybody had a nice summer. Are you okay, Kelly?
I am, yes. I had level 2 ACDF surgery back in June, and my voice has not recovered yet. So,
Why don't you? Well, bless your little heart.
it's fine. It's fine. I'm sure everybody is tickled pink that I don't have my voice back yet.
Well, I'm glad that you're okay, and I'm glad you're with us today.
Thank you. Thank you.
You're an important part of what we do. Get this moved over just a little bit. Okay. All right. We'll get it here. Now let's see if I can get this thing. Get my view a little bit better. Let's do a gallery. Whoa. No. I think I like this one better.
Dr. Thornberry, are you going to be Britain the Great today?
Do what was that, Judy?
Are you going to be Britain the Great today?
Britton, my daughter, Britton Thornberry.
Yes.
Yes, she's a hot mess. I was up at late last night working on mean absolute deviation with her. Yeah, I got rooked into that one. Yeah, she's a hot mess. I love that little girl. Let's see what I've got here. Is that Britton the Great? Oh, that's what you're referring to.
Oh, yeah.
Yeah. Well, my daughter does. She does voice lessons on her. I think a voice lesson was yesterday. So let's see if I can have the technology to actually. I don't think I had the technology to fix it. I don't know how to do it. I'm not gonna lie.
Well, we know who you are. That's okay.
Britton the Great. Yes, Britton the Great. I love my daughter. She's a hot mess, Judy. She's one of these kids that we measure our summer by the amount of books that she reads, and I took 8 trash bags of books out at the end of the summer.
That's a lot. That is a lot.
She's 11, and God love her heart. She's yeah. If I could change my background, I have no idea what she's done to me here. Does anybody have any suggestions? Do you guys know how to do this?
Well, you might get in trouble if you change it. I think I'd just leave it like that.
I have no idea what it looks like. I have no insight into this poor presentation I'm offering you guys.
Dr. Thornberry, Dr. Gupta is joining now, so that would give you a quorum. And if you do want to change your name, I say you leave it. But if you do want to change it, if you just hover over your picture and see the 3 little ellipses, you can click on that, then click on rename.
Let me try as I'm on behalf of the Commonwealth today. Let's see if I can even find myself here.
I really thought the transcript would be more interesting if you appeared as Britain the Great.
Well, my daughter is a hot little mess. I love her dearly. She keeps me well, I can't even find my own picture. I have everybody else's picture, everyone's, but the Doc's. Yeah, we'll give it another minute. Ashima, can you hear us?
I sure can. Can you hear me?
I do. I see you too. How are you doing? Did you
Good. How are you?
I'm doing very well, thank you. We'll give it just another couple of minutes and then we'll jump in here if that's okay with everybody. Yeah, apparently I'm Britton the Great today. Oh boy. You think you could find your own picture here? I'm not. I cannot.
Good morning. How are you?
Good morning. How you doing, Dr. Cantor?
I'm good. Thank you. Thank you. Good morning.
I'm Britton the Great today.
Yes, yeah.
Yeah, hello. There we go. Okay. I think that'll just about do it.
I believe Dr. Lyden is joining now, so that gives you 4.
Good. Good morning, Dr. Lyden. Can you hear us?
I can. I'm trying to.
Fantastic.
There we go.
I'm going to give it about 30 seconds, and then I'm going to start us if that's okay with you, Dr. Lyden. Okay.
Yeah, that's fine.
Good. Welcome. Hope you had a good summer.
I did.
Very good. Very good. All right. Kelly, are you about ready to go?
Yes, sir, I am. Go right
All
ahead.
right. Very good. Good morning, everyone. I'm Dr. William Thornberry. This is a October meeting of the Kentucky's Physician Technical Advisory Committee. We meet under the auspices of Title 19. We do have a quorum here with our members. I would entertain a motion to approve the minutes from the last meeting as our first order of business.
So moved. Second.
Very good. If there's no objection, we'll accept that and move forward to old business. On item 4, it looks like, let's see, we're reviewing the updated minimum cost study for enhancing primary care codes. Cody, could you share your screen with that, please?
Give me just a second, Cody. I'll have to make you a co-host.
Okay.
Thanks, Kelly. So as we kind of get things engineered here, I would say we firstly want to thank DMS and their leadership for authorizing the study. The physicians TAC has been working on this Medicaid physician fee schedule for the past couple of years, and I think we now believe we probably have a targeted approach with the projected dollar amount to the proposed enhancements. This critical information provides a clear picture for the true weight of resources to achieve the TAC's goal of mobilizing sustainable primary care within our Commonwealth. We'll wait on you, Cody.
Can you see it?
Can you guys see that? I have it over
Yeah.
here.
We
I
can
have it
see
on Very good. By way of background, for those that don't have prior knowledge of the subject, the PTAC has requested that DMS has completed by their partnership with Milliman 2 targeted studies for physician fee schedule. The first most robust study forecasts a projection to move that repeats all of the ACA designated primary care codes to 100% of Medicare physician fee schedule. That estimate totaled about $248.2 million. Of course, we'd have to keep in mind there's a 70-30 split between the federal and state governments. This would place DMS's burden at about $74.5 million per annum. The second study forecasted projected mobilizing only the 99213 and 4 codes to 100% of Medicare rate for primary care providers. Now that would include all providers, physicians, nurse practitioners, physician assistants. That is, we're talking about primary care not employed by a hospital, RHC or FQHC, and we've discussed the payment differential that those groups are under, and that's substantially different than the groups we're talking about here. That estimate was a more modest 130.8 million, and with the 70-30 split, my take on it was about 38 million. Cody, you'll have to remind me, but I think when I did the calculus on this, it came out to like kind of a rounding error, like it was about 0.2% of the budget that we're talking about here. And I could be a little wrong on that, but I think we felt like it was a rather modest investment to help sustain the primary care workforce, because a lot of these private practices across the Commonwealth are actually in these very small rural or underserved communities, both not only rural, but sometimes even inside the urban areas. Cody, do you want to chime in on this a little bit?
Yeah, I would just say that's part of the effort here in taking the much more limited approach, looking at the two specific codes and looking at the population of physicians that are most affected by a lower, Medicaid physician fee schedule. And so that being our independent practice, often rural, but also urban primary care physicians, as well as our other primary care providers, APRNs and PAs. And so that was in large part the thought behind just getting the projection for these two codes. Is how can we have, or what can be the biggest impact in the most targeted way? And that was how this was arrived at.
It looked to me like that, at least in the former study, part of the information or the data that we kind of sifted through demonstrated that the disparity for these practices in 99213 was exactly 50% of the Medicare rate. For 214 is functionally 50%, it's 56%. And just to be candid, I'm just unaware of any medical practice that's sustainable with that business model. And I think it's common knowledge, at least in our field, that since 2001, the reimbursement for physicians is down 29% over the last 23 years. There's no COLA or cost of living adjustment. And I think that these studies kind of add a little bit of meat to the skeleton that we discussed over the last couple of years. I would open this up to the members of the TAC for their opinions before we kind of bring in our DMS or MCO colleagues. Dr. Neal, do you have a thought here?
Well, there was some discussion early on as how this would affect everybody because 60% or so or more of our primary care physicians are now employed, and the not-for-profit hospitals are getting Medicare rates now for all outpatient procedures, outpatient visits, as I understand it. And there was the question of, would this be passed along to the physicians? And a couple of hospitals that I've talked to said, well, they'd look into that, but no, that wasn't certainly being directly passed on. So that kind of comes up as a question in my mind.
Mm-hmm. Dr. Gupta? Dr. Linden?
Do we want to bring up what happened at the KMA meeting at all regarding this?
I was unaware of it. I was there at the meeting, but I don't recall this. If it was brought up, I don't have any recollection of it. I had my mind on some other business at KMA. Dr.
Okay.
Lee, yes, go ahead.
We did submit a resolution regarding this, and the consensus, they did end up passing it, but they wanted all the codes. Is that right, Cody?
Yeah, there was a resolution passed at the KMA annual meeting that directed the KMA to advocate for enhancement to all of the physician fee schedule as it relates to the Medicaid program. And I guess that kind of gets us to where we are now in so far as affecting the change to the physician fee schedule in this way. Is that it will have to be a legislative approach, given that we're not in a budget year this year. It's likely something that could be up for discussion and be addressed in the next budget session in 2026.
Well, if I was going to try to look at this as objectively as I can, let me take the other side of it and see if I can reason my way through it. If I'm just moving even over the major codes, which is 213 and 214, why is 0.2% of my budget? Why is that important? It just seems like, everybody's going to whine about, no one that I've ever met's ever paid what they think they're worth. Okay. So why is this important? But I would say that there's a Pareto optimum here of a point in the scale when you kind of eventually just the last straw kind of breaks the back of the camel. And so the practices that we're talking about here, the ones that are not employed by the hospital, the ones that are not under like paying doubles. We'll call it RHC's probably getting double. FQHC's probably getting triple. Well, if you don't count those practices, why is this tiny group of people important? Because I would say that these are the people that actually are in these rural areas and keep the Commonwealth kind of going, because really you're not talking about the sick care system like the cough and cold. You're really, to me, talking about the chronic disease system. And these are the people that have they don't work for money. They work because they have a belief in their life, or a belief in the system that they're trying to make a difference. And these are the people that take care of that kind of at-risk population. You kind of lose these people, and all of a sudden this tiny group of people that kind of help things stay under control all of a sudden they end up in the ER, and then the ER just trying to get them out, because either in the ER you go home, you go upstairs, or you go to a tertiary care center, but you don't stay. So they don't really care about the chronic disease care. They're saying, get out of my ER now. If you don't follow up the chronic disease care, what may not get you now, but in 2 or 3 years, all of a sudden, well, now you're on dialysis. Or you just kick these people over to RHCs or FQHCs, and now the Commonwealth's on the hook for a lot more money. So it seems like to me, it seems like a pretty modest investment, but they may not see it that way. I guess the MCOs may not see it that way. But I think the legislative fix would be to try to say, can we reason to a system with a teeny tiny amount of investment? Again, at the very most, you're talking 75 million of what's the budget here? 18 billion? Is that the budget for these guys? I mean, Cody, do you know the number? I just don't know off the top of my head. It's a pretty big number.
Yeah, it's about 18.
Yeah, okay, about 18 billion. So, I think you say, well, what we want to try to do is find the most modest investment to give us the biggest outcome. And this is, I think we're aligned with Starfield's model of primary care being the best outcome. I used to say generic drugs, but I'm not going to say that anymore. But I'd say primary care, which can offer, you're asking us to do 2 or 3 things. I think this is a pretty modest investment. Again, even if you're talking about these tiny codes, you're talking about half that much. You're talking about 0.2% of the budget. And I think the outcome to make these practices at least sustainable, even half of Medicare rate is, that's, I don't know. I would open it up to our colleagues from the department or our MCO colleagues. I just would like to see it their way, or maybe they can help me understand this a little better. And I just have an immature way of looking at it. Is there any thoughts on this?
I have my hand raised. I have my hand raised.
Yeah, I'm sorry. I just can't see it. Go ahead, please.
No problem. This is Chirag Patel, CMO at WellCare.
Yes. Hi, Dr. Patel. Welcome.
Thank you. So I, like you, 100% agree. Primary care medical home, that's the backbone of delivering good chronic condition management in the universe, not just in Kentucky. But I also am a pragmatist. We would be supportive of increasing the value proposition of the codes, but we would like to look at the problem in totality. Like, the BH providers and the BH utilization and cost is driving some of this other behavior where it's rob Peter to pay Paul. Now, if we could bring that under, the 50th or 75th percentile, maybe there'd be more resources, attention to the real problem in delivering chronic care condition management.
Yeah. Thanks, Dr. Patel. Does anybody else would anybody else like to chime in here, please?
So, this is Dr. Lydon. I'm a psychiatrist, not in the primary care, but I think what we're talking about is very important. Even for myself in my office, it's a struggle to make ends meet. It's a struggle sometimes to, when I'm looking at the checkbook day before payroll to see if I got enough money in there to meet payroll. And you look at kind of reimbursements and where we're at. And even working with other organizations. I'm also very involved and work with Communicare in Central Kentucky. And we see a lot of patients. It's just, I know budgets are tight or budgets are lean, but the other thing is when you're looking at trying to provide services, it's harder and harder to stay in practice. It's harder and harder to keep office doors open if the reimbursement isn't there. And I think it starts somewhere. And I think starting with, the primary care, starting at the bottom of the pyramid to try to solidify it is a good place to start, a good place to look. And I think we're headed in the right direction with this discussion.
Thanks, Dr. Linden. Does anybody else have a thought on it?
I guess the
Well-
question is DMS able to allocate that 0.2% now without legislative action?
Hi, this is Justin Derringer, Director for Division of Healthcare Policy. How are you all?
Hey, Justin, thanks for coming.
Absolutely. So the answer is no, not currently. So the budget process, like I said, it's not a budget year. That budget's been set for the next 2 years. That would have to be an increase that was done through the legislature so that we could have those additional funds. As you all know, there is I believe there was a $25 million increase next year, which was in 2025, but that money was appropriated through the legislature to be determined by LRC as to which how that was utilized. So Legislative Research Commission will let us know where that goes and who that goes to, that 25 million. But as of right now, that answer would be unfortunately not. And we realize that not only physicians, but we have a lot of provider types that with rise of an increase in cost that would need some increases at some point.
And hi, this is Dr. Terrio. I think it's a little bit more complicated because we'd have to do a rate study as well. And that we'd also have to do a SPA and do different things. So it's unfortunately not something you just click and turn on.
And I think that's, Dr. Terry, I think that's consistent with the sentiment that we've had the last couple of years. And I think we all respect the administrative way that DMS is set up. Cody, you can remind me about this, but I think we've already forwarded our recommendations on this like a year or two ago to the TAC. Am I not mistaken on that? I'm pretty sure I'm right.
Yeah, you're correct. The MAC has discussed this previously, and just from KMA outside perspective, this is something that we're working on with the legislature as well to try and address. So we certainly understand the budget constraints within DMS to move funding around on this issue.
Dr. Gupta, was it 1 year ago or 2 years ago we sent that your all's way?
I feel like it was last November.
Okay.
Cody.
Well, I think at this point, I think this is more informational and it tries to move us. I think the way I would try to see the TAC looking at this is, I don't want to see this as the whiny children that always want more. I would rather see this as a way to move our policies forward, to give us more of what we need in Kentucky. It's certainly self-serving because you're talking about in the physician's TAC, but even if it weren't the physician's TAC, I think this is the way I would want to try to proceed, trying to invest the smallest amount of money for the biggest outcome. But, and I think we'd all understood that this was going to be a legislative solution. I'm glad it ended up being such a modest amount. And I think we just have to ask our legislators how they feel about this. But, I have a philosophy that people get the government that they deserve. Whatever it is you vote in, you have to live with that. And I can tell you in the last 3 months, I've known 2 practices that have gone out of business, 2 private practices that had one guy, he called it retirement, but he went out of business. And the other 2 guys left to go to a different state. They said they just couldn't do it. Now, I'm not saying, I do not want to infer that this is related to Medicaid, but I would just say that that's part of this process. And if we're trying to recruit physicians or other practices for primary care in Kentucky, well, I think this is one of the things that we'll have to communicate to the legislature. And I don't want to beat this one over the head. I think we've already discussed this kind of ad nauseum, but again, I think this adds some meat to the bones of what we were talking about. Is there any other thoughts on this before we kind of move us forward into new business? But
Yes, Dr. Thornberry.
yes, sir.
Don Neal, just very quickly. the unthinkable, that this budgetary change would not come from DMS, that this would come out of the budget of the MCOs. We in primary care are becoming not-for-profit. That's kind of what you're talking about. They seem to be for-profit. Is it possible that some of those increases could come from the MCOs monies that they already have, and that it all not have to come from Kentucky's budget? I'm sure that's the unthinkable, but it seems to me as we transition from treating sickness to treating wellness, and we are trying to improve the situation of the health of the citizens of Kentucky, and particularly those on Medicaid, that in the long run, it would save them money to have those of us in primary care who I feel are delivering very good primary care, but we're not going to be there. It's simply, we're not filling our residency programs. And I'll be very brief about this, but I just think that we may need to think out of the box on how this happens and ask for help from them, which will help them in the long run. Is that nonsensical?
This is Stuart Owen with WellCare. Could I chime in a little bit?
Please, thank you, sir.
Yeah, and so I'm just going to be very candid. It's a great point that Dr. Patel brought up, and I don't know if you all are aware, but since the COVID pandemic, the Department of Medicaid Services has prohibited any kind of prior authorization or authorization after any threshold for behavioral health, and also no limits. And also in late 2022, increased the rate for psychoeducation on the behavioral health fee schedule by about 350%. And unfortunately, that environment has been greatly exploited by particularly addiction providers. And so I know that's kind of the perception, MCO is making money. We're not making money. We are not making money. And the behavioral health spend has been completely out of control because it's been exploited by some unscrupulous providers, certainly. And we've been lobbying, and we've been lobbying for the psychoeducation rate to be dropped back to what it was, and you could use that funds to pay like a primary care, for example. And so that's been a huge, I'll tell you, MCOs are not making money, and a huge cost driver has been the out of control, particularly addiction, behavioral health spend. And the argument is access, and we've argued access to what? Because it's particularly providers that have a business model of providing a high volume of very low value / non-clinical care, because it's low wage, high profit margin services. And it's all about profit margin, and they hang on to members and hang on to members and hang on to members, and it's not resulting in clinical outcomes and helping actual Medicaid members. So there's a great, I'm talking about a huge amount of money being spent on that. And that's like a very serious cost driver, a huge cost driver for the MCOs, but we're not making money.
I appreciate your insight, Stuart. Thank you very much.
Certainly.
For a lot of us that don't follow things like buprenorphine, that's wasn't clear to us.
Well, the buprenorphine is fine. It's actually it's peer support, and a particular they have an army of peer support. So if you're a Kentucky Medicaid member with addiction, unlike with medical, if you had a medical condition, you're getting a great deal of peer support, which is essentially AA and emotional support. Because we have providers, they hire an army of them. It's cheap. It's GED. You have to have a GED and the disorder. And so that's what they're rendering a super high volume of. And also psychoeducation is another service, like I say, where they increased the rate by about 350%. And we immediately saw a provider shift from clinical care, like intensive outpatient patient or program or psychotherapy, to psychoeducation and peer support. That's what you get if you have addiction. And again, it's a huge cost driver. So it's not the clinical stuff. It's either the very low value, like a ton of psychoeducation, which is basically explaining your care. That makes sense on the front end when you're starting treatment or checking in every now and then, but not like 14, 16, 20, 30 hours a week. And then same thing for peer support. So anyway, that's the problem. It's substandard care actually, and we would not accept it with medical, but we are with if you've got addiction, unfortunately.
Yeah, I would like to, I can reiterate that. I work down in Hardin County. This is Dr. Lyden, sorry. And I see on the inpatient side here at Baptist Health Hardin, we get a lot of folks from a lot of those unscrupulous kind of halfway houses, sober living houses. And that is a problem, just like the gentleman before me was stating. I just want to make sure that when he clarified at the end that it was substance abuse treatment. Initially, it was behavioral health. It's behavioral health, not the problem. I think a lot of the substance abuse treatment centers are where it is not a medical model, physician-driven treatment or organization. The non-physician substance abuse treatment programs are a problem. I see a lot of the folks that are enrolled in those in the hospital on the hospital side. So it's not, I'd be careful of lumping it into behavioral health. And one of the net should be cast just on that substance use, non-medical, non-physician driven entities and treatment programs.
Yeah, agreed. It's the addiction providers. You're right.
Dr. Thornberry,
Yes,
you have a
ma'am.
couple. You have a couple of people with their hands raised.
Yeah, please.
Dr. Teichman, I believe, was first.
Yes.
And I hope I didn't butcher your name, sir. I'm sorry.
Close enough.
Yes, Dr. Teichman.
Jeb Teichman, I am the Chief Medical Officer for Passport by Molina.
Yes, Jeb.
I want to agree with everything that's been said by my colleagues at WellCare and Anthem. I also want to point out as to the profits for the MCOs. I don't know if you're familiar with or you follow this street. Yesterday, Evelyn's Healthcare reported their earnings missed their target and their stock is down 12%. And that's solely because of, it was blamed on the Medicaid book of business. That sunk all MCO stocks. So yeah, we have finite resources. We have to be good stewards of their resource. And as a primary care physician myself, I totally support this effort, but it's a matter of taking money from Peter to pay Paul. We have a finite resource. We have to figure out how to use that. We have the dentists with a problem as well. And I agree, it's all about access. And I surely don't want to see practices closing, but to Dr. Terrio's point, it's not a matter of just flipping a switch. Even though we support this, it will affect the rates. A rate study has to be done, and then the legislature has to agree to up the rates.
Thanks, Dr. Tishman. Do we have another person with their hand up?
Yes, Dr. Cantor.
Good
Yes, Dr.
morning. Hi, good morning. Thank you. I couldn't agree more with my colleagues as well. I would like to add that and confirm in terms of where the profitability margin has weakened, UHCs in a similar vein. But what I'd like to say is that it's important to not dilute the distinction between paraprofessionals and professionals from a rate perspective. If we're going to dilute the professional rates, it'll make Kentucky a harder state to get more professionals to come and stay. It's not the first time that our DMS colleagues have heard me say that, but I think it's worth repeating and keeping that in mind as the rates are being evaluated for 2025 in the future. So I feel like that's a pretty clear statement. So if there are any questions, happy to articulate further.
Thank you, Dr. Cantor. Let me see if I can move us forward. I think what my take on this is we all have a shared vision here of the frustration that our Commonwealth, and again, I'm looking at it through the lens of the physician TAC, but I'm trying to take a more broad-minded approach. But I think we all have a shared vision of the stress. And I would suggest that that ironically, on the appearance, that both the MCOs, likely DMS, and the physicians here are all suffering the same consequence when we only have a finite amount of resources. And right now, it appears to me, and I think the evidence likely suggests that we're putting resources into a place where you could double or triple the resources, but you're not going to get any better outcome. The problem is when those resources go into one direction, the things that could provide value for the Commonwealth are being, well, they're not being paid attention to. And when that happens, we're going to get a poor future. I know here in Glasgow, we have a residency and we matched 2 of the 4. And when I went to query, I said, was it just we're not doing a good job? Is it we're a bad residency? Well, no, it's just the people that don't want to come here because they don't see a future in Kentucky. And I said, what do you mean? He goes, well, they try to go where they feel like they're going to likely practice. And he goes, no one wants to practice in Kentucky. So they can't get kids to come here. And I know Dr. Neal's kind of alluded to this, but I think we're seeing the canary in the coal mine having difficulty. So I think when we all move to the legislature, I think it's not inappropriate to suggest that all of us look at this the same way. And I think our message, our shared message to the legislature should probably be, gentle ladies and gentlemen, can you please look at the value of the resources that you're moving forward in these paraprofessionals that aren't providing what we feel like is true value, and try to provide the resources in an area where we think we can get long-term value and better care. I think, I don't think we need to move any more resolutions forward. I just think that we can all come to an agreement. And that's probably what the minutes ought to suggest, Kelly, is that we all share an agreement on the likely move forward, and the move forward is legislative. So again, I think when we all speak, it would be appropriate to suggest that all of us do see this the same way. Is there any dissension about this philosophy? I'd want to get that on the record if there is a dissension or someone doesn't see it that way.
I would just add that when you go to the legislature, make sure they have an appropriation to go with the change, because oftentimes they will make a decision like this one, but then not do any appropriations to pay for it. And when that happens, we have to stop providing other services. But I would like to actually talk about some ways that you can now increase your rates, and that would be by entering into a value-based program with one of the MCOs. Since you are, the primary care, the main primary care providers in your areas, and, if you want to, take on, I don't know, congestive heart failure or something like that, and you can, you're doing a great job of doing that, the MCOs can have a personal program that they create with you as you are doing a good job and meeting metrics, they will give you more money on top of just the claims. So I don't know if any of the MCOs want to talk about that.
Would anybody want to chime in from our MCO colleagues about that investment?
Yeah, I will. So, hey, this is Chuck. I think conceptually that sounds fantastic. Let me talk about what's happened nationally, and then I'll talk about what's happened in Kentucky. Nationally, what we're seeing, particularly in the government-sponsored insurance space, that less and less providers want to engage in value-based care because there's a lot of effort, administrative and clinical, to reach those dollars. And then in Kentucky, we have, I think, over 80% of our providers in some type of VBC arrangement, upside only. That means pay for performance. That means you close a gap, you get paid. Does that translate necessarily to chronic condition management? It doesn't. It's a transactional activity. Nevertheless, what we found, especially in our more critical access and rural regions, that providers are not set up to do these activities from a clinical standpoint, from an EHR standpoint, or an admin standpoint. And we often see providers leave 20, 30, 40, 50, 60% of their allowable earned dollar left on the table. And we look in totality, it's several $1 million by Medicaid book of business. And that includes pediatrics, right? Respectfully, we have a 2% withhold program with the state, right? Which is several tens of millions of dollars per MCO. And we actually cascade those exact same metrics word for word down to the provider, and the providers are unable to do those things for us, even though we give them the list, we put resources in their practice, we'll make calls for them, and we're still not able to do it because it's an inefficient model. And so while VBC was touted as the panacea, it is absolutely not. And I don't know necessarily if that is a lever that we can pull for any meaningful change, full stop.
I certainly understand that and appreciate how difficult that is. I think part of the part of the challenge there is on the one side, you know, when I look at the MCOs, you know, they're in a world of data. They're in an administrative world. That's how they view the world. The practices, of course, they're just trying to take care of what comes through the office through the day. And particularly, and we're talking about these rural practices, these people that don't have special contracts. Well, they're exactly the people that probably can't provide that kind of data. And the sad irony here, I think, is what you alluded to, is 2% of the budget. But to fix the problem, it takes 0.2%. It takes a tenth of that to likely improve the problem. That's the sad irony here. And it is a challenge. I think you can meet the 4 pillars of congestive heart failure care, and nobody may know about it except the fact that your patients are doing better and using less resources. But you're right. If you can't prove that, and I don't see that these practices will ever be able to do that. They just don't have the resources to do it. They can't hire the people. And no offense, but when you're getting half of Medicare rates, of course they can't afford the people to do it. So I think, again, moving to the legislature, we would have to ask them to have the wisdom to understand this. But I think they will have to have that wisdom. I don't see that the practice could do it themselves, at least from my view. I could be wrong. Dr. Neal, do you see it differently, sir?
No, I do not. I agree with you.
Yeah. But it's certainly nice to have an insight. And actually, it's nice to actually all be looking in the same direction together for one time. Sometimes I come to these meetings, it's frustrating that we're all trying to do the same daggone thing. And there's an appearance that it seems like we're on opposite sides of the table. And I'm not really convinced at all that we're on the opposite sides of the table. I just don't think we're all communicating in the best way. But I think today we do share a common vision. Is that fair enough to say? Well, since we're moving to the legislature on this, I think we all have enough ammunition to at least speak on with insight into the others. I'll just take us forward here to item 5 on new business. The first portion was reviewing 907 KAR 3005. That's the data limitation of EMS services. This was kind of a new issue that came to our attention over the last 6 months or so. We've been alerted to some concerns by a number of primary care and pediatric practices regarding 907's language and its administration. Presently in section 4, subsection 7, there's language, and I'm going to try to quote this. Correct me if I'm wrong. Coverage for an E&M service shall be limited to 1 per physician, per recipient, per date of service. And so I think practices attempting to remain respectful in the compliance of CMS's 2021 CCI correct coding initiative and the revised CPT coding guidelines have found challenges providing the standard of care services, what I would consider standard of care for primary care and preventive medicine with appropriate reimbursement. Cody, you've done some work on this. Can I kind of pitch the ball over here to you to kind of step in for just a second before we move forward on this?
Yeah, sure. So this is an issue that we've heard a lot about over the course of the last 6 months, particularly from our primary care physicians as well as our pediatricians. And it's creating a lot of confusion and difficulty amongst practices, both in terms of billing and providing care. And particularly when it comes to billing for a visit where, say, an annual wellness exam and preventative medical care provided in the same visit. So in other words, the patient submits for their annual well visit, but also receives treatment for, an untreated chronic condition. And so the physician then addresses, both of those issues, and they meet both the time and the medical decision-making standards. But then when they go to submit for reimbursement, they're only able to be reimbursed for essentially one of those services due to the prohibitive language in the regulation. And so it's just causing a little bit of confusion and difficulty amongst practices. And it also, at least the latest national CPT guidelines that we've looked at, they don't prohibit this billing practice. And I believe Medicare, it doesn't mandate that payers cover both, but they allow for both to be billed, but with a modifier 25 attached. Of course, so long as the time threshold and medical decision making is components of those codes and those visits. So yeah, that in essence is what we've been hearing about and what we're seeing.
Well, I guess what's the committee's Dr. Gupta, Dr. Neal, Dr. Lyden? How do you all look at this? And have you had any challenges here?
I can tell you after 60 years of practicing pediatrics, with a
I
certain
think for me in a specialty practice,
Let me put Dr. Neal, who started, and then Dr. Gupta, I'll come back to you. Thank you. Donald?
Okay, I'll be just brief as I can. With every well child exam, there may be something else, a type of rash. You may find an ear infection, or they may have called for a sick visit and needed a well visit, so they get that added. This gets complicated, but it's just a futile effort of the primary care physician trying to eke out enough pay for the patient that he sees to keep him in business. And I review charts all day, every day. And so what I'm seeing in the EMR is there are 2 visits. And interestingly enough, that creates 2 charts if they want to be paid for 2 different visits. And interestingly enough, in one chart, it may show the ears normal. And in the other record that's created, it shows the ears abnormal, and which is a kind of anomaly that's created from that. But the bottom line is the only reason this really exists is that we're just trying to eke out enough to stay in business, not to make a profit to get rich. And I just, as an older physician, this whole thing of this extra visit at the same time bothers me. The surgeons had a different reason for it, because they do a surgical procedure and do something else on the same day. But that's different for the primary care doctor. We're adding these as what we call split visits, but it's just a way to, everybody's trying to game the system. And I don't know any other simple way to put it.
Dr. Gupta?
no, I don't really have anything to add, especially from specialty care.
Yeah, I like to think of my clinic as more as a chronic disease clinic. I think part of this frustration is we have many of our MCO medical officers and Dr. Terrio, of course. This is kind of a more part of the revolution of it's spinning back around again. But primary care is a really unusual part of our health system, and it's unusual because when we came up with CPT coding and reimbursement, well, there's one way. For example, our specialty and subspecialty colleagues are paid because they come in, they look at a problem, and then they go forward. Primary care does it different. They attempt to pay it the same way, but they don't perform the same function, and so that's why it struggles. On the one hand, you want them to provide sick care, cough and cold and UTI, and this, that, and the other thing. Then on the other hand, you're asking them, well, we want you to prevent stuff down the road because we don't want a sick care system, we want a well care system, and that takes time to work with people to try to explain to them why they need their colonoscopies, why they need to be in front of the ophthalmologist for their eye care, why we need to get these immunizations. And then the third part of it is, particularly with these adults in Kentucky, we have these kind of very sick group of people that use a lot of resources. And, they have the diabetes, the hypertension, dyslipidemia, the heart failure. And we're trying to keep that in check. And yet, in the same visit, you're almost trying to do what I see is in my office. I mean, my patients are like, maybe just because it's people that I get, but they come in for their diabetes, hypertension, dyslipidemia, and they have a little, they sprain their ankle. I don't know. They have little something else going on. Then on top of that, you're trying to say, listen, you missed your colonoscopy. We talked about this the last couple of times. You didn't keep your appointment. I want you to get this immunization. You're trying to do that in all one way. Now that is in and of itself the problem, but the challenge here is, well, how do these practices, again, these are the practices that are struggling, how they at the 50% of Medicare rate, how do you do all of that? Because just the staff it costs to generate all the care that they need is a money loser. But how do you do all that at the same time and then be sustainable? And you say, well, these are the rules that you're giving us. You're giving us this 2-5 modifier. You're giving us that, this, that, and the other thing. And Cody, again, correct me if I'm wrong. I know there was some information came out yesterday, but I think the thought today was you're going to try to provide the care visit that they came for, and for some of the MCOs, you can provide a 2-5 modifier and try to say, well, this is what we're doing. We're telling you what we're doing. We're trying to be honorable partners. Again, this is a CCI initiative. We're trying to, at least in our practice, we try to be as honorable as we can. Am I seeing this the right way, Cody, or am I looking at it the wrong way?
Yeah, no, you're right. And there's been a varied approach to this by the MCOs. They've kind of, the ones we're aware of and have heard about, those situations, it's been a little bit different. I know Anthem did a policy change this year to make it 150% allowable of the build code when there are 2 E&Ms in one visit. So we appreciate, certainly appreciate that effort. I think that's a step forward in the right direction. I don't know if any of the MCOs would be willing to share how they handle this currently. That might be helpful for you all.
I would welcome their insight. Can you guys can chime in again? I'm sorry, when my daughter has my damn screen set up, I can't see people raise their hand, and I'm not smart enough to figure out how to move it around. Can you all just kind of chime in for me?
I was just going to say, this is Stuart with WellCare, and I honestly don't know.
Well, it looks like, Stuart, that kind of what the administrative way around this is you bring them in for one thing. You say, well, you know what? We're not reimbursed for this other thing. We'll bring you in for another time to talk about, we're going to do your preventive medicine. We're going to bring you another time to talk about the diabetes. And then what eventually would honestly happen was, well, they wouldn't come back. Now, they couldn't afford to get a ride down. Some of our people pay like $90 to come to the doctor. That's why we pay a lab. We don't make money. We pay a lab to come in so that people have a place to go to the doctor and have a lab at the same time because they can't be transported. So what would happen is they would come in once, but you'd ask them to come back again. Well, you put them on the schedule and they might think they could come. And I'd say 70% or 80% wouldn't come. And the problem there is, of course, now there's a hole in your schedule and the practice becomes less fiscally sustainable because they're inefficient. And so and then you say, well, we're going to try to capture under 2 charges at 2 different dates. You promote a system that's inefficient because you're not trying to exploit the MCO. You're saying, well, this is the care we're providing. We just can't provide it. We just can't bill it all at once, provide it in one setting. It just seems like that nobody really kind of gets what they want with that. It seems like the more you try to avoid it, the more problems it causes for the patient and the professional. And eventually down the road, it causes trouble for the MCO when their diabetes kind of goes haywire. That's the way I see it, Stuart.
Yeah.
Yeah,
I mean,
sure. So I see the point.
Yes, sir.
But I think the truth is probably someplace in between, right? Like I alluded to the several millions of dollars, hundreds of thousands of dollars that the PCPs are leaving on the table. If you brought that kid in, did that combo 10, you'd get an extra $60. Or you did the A1C and did the microalbumin, you get another $80. You wouldn't have to bring that second time in. And so, there are business is a game, right? And so there are other ways I feel like that the providers could reduce the actual clinical burden and reach a higher revenue stream. But that requires the front office staff and the fiscal leadership of that practice to be savvy to what's written in those contracts. And we often find that there's a huge gap in understanding what's actually written in those contracts. And what the physicians do is just churn and burn through patients and think that's the only way to get to that end margin. And I think that's a huge gap.
Well, I think you're probably exactly. I think it's extraordinarily good insight. It kind of reminds me of the analogy of like, you have a child and you can have the candy if you can jump up to the shelf to get it. But of course, it's on a shelf they can't jump up and get. And I think that's one of the challenges. I wonder how our MCOs, our NCO partners could work with these practices to help educate them to say, listen, if you're doing this, can we help you understand the administrative part of this? Because we want better care for these patients. And can you, that would be my thinking. And I wonder how much we're missing in our practice because we just don't understand it. You know, we're not contract experts. We're medical experts.
Well, here's something I would ask all you guys on the call to do, just a litmus test. I would say these value-based contracts probably change between 5 and 15%. Every 2 years, metrics change, denominators change, nuances change, right? And so the way to get to the money changes. Ask your person who's your contract person, hey, has our contract with such and such or any of the Medicaid MCOs for quality changed in the last couple of years? And if they say yeah, ask them what changes, see if you were notified. If they say no, that means they're probably not well informed with the language in the contracts or the amendments. And then that'll give you a litmus of where you are in terms of really earning the top dollar available in those said contracts.
Thank you.
I'll chime in. This is Herb with Humana. I will say that we do abide by the modified 25. So we follow CMS's guidelines. We also follow the standard NCCI P2P guidelines as well, you know, the procedure to procedures as well. If there's an interest, and if Stuart's okay, I can take this back to the all MCO meetings that I hold on Fridays. Normally it's not today, but normally it's on Fridays, and we can at least bring this back up to the rest of MCOs and see if there's an appetite to see if we can maybe possibly streamline the ability to utilize that modified 25 across all the MCOs. I mean, I guess it doesn't hurt to ask.
Well, I would like to just step aside from my presiding officer position to just say, as just a member of the TAC, in my work with Humana, they've been exceptionally good about this. Humana does provide in my mind, and I might be wrong here, but they provide a comprehensive preventive examination for our people. We see that they get in and do that. We actually make an effort to get in and do that. And at the same time, we do work with their chronic diseases, and we set aside special time for that. It's not just this and that, but we do that. And it's worked out very well for those patients. And they've been extremely pleased with that program. So I would say a tip of the hat to you guys, at least in my private practice, we've seen a very good result, and it seems to be working for us to the best of my knowledge. And I would thank you for the consideration.
Sure. You know, and if anything, and I'm not just saying this for Humana, I know it's true for all the MCOs, but you know, we absolutely are hyper focused on preventative measures, right? We want our members to be preventative of whatever the issues are going on in their life. It is so much smarter to prevent something happening than to then go back and treat something that's now occurring because we didn't prevent it in the first place. So, you know, and Humana, if you look at everything, and again, I'm not trying to single out just Humana, but everything that we try to focus on is that preventative thing. And that's true for the member, right? They would rather get their flu shot as a preventative measure, hopefully, than having to suffer the consequences of getting treated for the symptoms tied to a flu. And so that's why, you know, we put that out there, that modified 25 to distinguish that this is a separate, you know, visit, like a separate item that's being addressed with the member that should be documented in the medical records. And that's also in addition to the school sports physicals that we offer as well, separate from the E&M visit.
Yes, sir. Does anybody else have anything anybody else would like to add something here?
This is Ashma Gupta. I had just a question about the value-based contracts. Do those only pertain to primary care or also to specialty practices?
I guess I could chime in on this. This is Jim Teichman. Our VBC contracts are primary care driven. The quality measures are quality, are primary care things like immunizations, well child visits, well adult visits, A1C, colonoscopies, mammograms. They're different goals for pediatrics and adult. But the VBC programs we're talking about are primary care. There may be other programs for the specialists, but I haven't seen that yet.
Okay, just curious. Want to make sure we're not missing out on anything.
Yeah, Dr. Gupta, this is Dr. Brunner Anthem, and it is primary care, and also we have some in the obstetrical world as well.
Thank you.
And Angie Parker with Medicaid has her hand raised.
Yes, Angie.
Good morning. Hi, I'm Angie Parker. I'm the Director of Quality and Population Health with the Department for Medicaid Services. And Dr. Thornberry, I believe you worked with us a few years ago when we developed the quality strategy.
Yes, ma'am.
Yes, and so we do have that. And I don't know if I have presented at this TAC regarding the value-based purchasing program that we have with the MCOs. And if we have not, I would be more than happy to share that with you all at a future meeting. But we do have 6 measures that they've talked about earlier that the MCOs, and we keep 2% of their capitation rate back for them to make sure that they are targeting these specific measures. 3 of them are immunization, well child visits, and diabetes control, as well as social determinants of health. And then they can also be eligible for a bonus pool. And if they meet 4 of the 6, I believe, but I could be wrong. I've done this plenty of times. I should know all this, but anyway, I would be happy to present that information to this TAC if you think it would be useful. But we do know that they are primarily primary care driven, I would say. But there is some, because we're focusing primarily on the chronic condition of diabetes and childcare for these measures.
Well, Angie, I do remember working with you. Yes, ma'am. And let me stay up front that I want to appreciate all the work you and your team did. That was a lot of work. And yes, ma'am, Cody, I'd like to put this on for the next agenda. We can kind of tie this into the work that our Humana colleague is leading with their group to see, again, our goal here isn't to eke out more money for any group. What we want to do is we want to put the resources that we all have in the best position to help the most people. And I think that, again, based on Starfield's medical home model, that in our health system, we ask primary care to predominantly do these preventive services, not solely, but the great majority of that is in primary care's hands. So that's why we're going to look in that direction. But can we put this on the agenda, maybe kind of tie this together so that we can kind of see if we can begin to move the ball forward? I know we all want to try to accomplish the same goal here, and maybe we can find a way to thread that needle so that we can get some better insights on how people are working. Cody, can you see that we do that next time, please?
Yeah, I'll pin those 2.
Yeah, we'll put that up on the agenda firstly. Is there, thank you, Angie, very much for chiming in there.
Yes, I mean, quality is, I can talk about quality all day long. So, I mean, and
indeed we shall.
And it comes down to, that was brought up earlier, network adequacy and making sure that people are showing up for their appointments. So there's a lot of little different areas that are hard to target, but I would be more than happy to provide some additional information on what that.
Does anybody else have their hand raised, or does anyone else want to talk about this subject?
I was just going to second what Angie had said. It's definitely more tied to the primary, but there also are value-based stuff tied to the BH side. So she'll have the more comprehensive information on all of that. And again, this is heard from Humana, and I will take back that 25 modifier discussion back with the rest of the MCOs discuss on our Friday calls.
Well, Herb, let us know how that, if you'd like to present, again, that's a little bit of a challenge. That's a private group, and you all have your meeting. If you think it's appropriate, we would welcome you to be part of the agenda. If you don't think it's appropriate for any number of reasons, we would not certainly would not want to press that issue with you guys. But again, if we can move together. I'd rather do this together and try to solve this problem as opposed to be pulling against each other. But I would welcome that as the best to try to find the best way to provide again preventive care for the long run. I think that's just the wisest dollar investment we have.
Yeah. I mean, you could put me down at least for a follow-up on the next TAC on this, but you know, again, every MCO has their own opportunities to make their own decisions, and Humana can't force United or Welcome to do one thing. So, but we can at least talk about it.
If there's a shared opinion that you all would like to present together, that would be great. If it's
Okay.
not, we'll accept that for what it is. Cody, can you make sure that you iron out the rough edges with her so before we get there, so that we have kind of the meeting runs the best way there? Would that be okay, sir?
Yeah, sure. Absolutely.
Okay. Well, let's move us forward a little bit into our other new item agenda, which is I have it on my agenda as recoupment. And generally speaking, recoupment has become kind of a more substantial topic for us as well. I want to open it up to conversation. I know Dr. Gupta in particular, you wanted to address this matter. Ashima, what's your thoughts here?
So this is just mainly from personal experience this past year from mainly from one particular MCO that I've been receiving several letters requesting recoupment for patients who were eligible at the time of service. And when I, spoke with my rep, I was told that that this was a decision. I guess like Kentucky Medicaid had made that change, and so I guess those patients went to Kentucky Medicaid for a brief period of time. And this is basically for me personally, it's newborns that I see in the NICU. And so, there's nothing that I can do about it. They just take the money back. And some of these are from almost 2 years ago. And it's just so time consuming and so difficult for me to have to deal with that. And I guess my main question is, it's mainly from one MCO. And I'm just wondering, like, is it just a ticking time bomb that I'm going to hear these from the other MCOs? Or why is it just like one MCO that's having this issue with, that Kentucky Medicaid is telling them that after a couple of months now that that baby is no longer part of that MCO for that period of time.
Ashima, let me understand this. I've heard this come up a few times, and maybe I'm misunderstanding it. But and Cody, please help me to have my mind around this. But is this one of those circumstances where the physician or the health group, the group is providing care, says, "Well, we've checked this beneficiary is covered," and you get a confirmation, you provide the care, and then somewhere down the road, 1 month, 3 months, 6 months, a year, they say, "Well, it turns out that we're going to deny coverage, and even though we told you they were covered, we want our money back." Is that right? Or am I misunderstanding that?
Are you asking me?
Yeah, Ashima.
Oh, sorry.
Is that correct, or am I
Yeah,
totally
that's
just
what it
wrong on
seems
that?
like. That's what because now when I go back to check eligibility during that time, yeah, now that MCO is not showing up as active. Now they're part of, active with Kentucky Medicaid during those certain visits. Like maybe the first visit was covered, and then like, I see these babies like every 2 weeks while they're in the NICU, and then they're no longer covered. Now, when I go back to check those visits, now it's Kentucky Medicaid. And but it's really just with this, mainly with one particular MCO. So, I mean,
Okay. Well, Cody,
I don't
can
know.
you help us? Cody, can you help us provide a little sunlight here?
I'll say Justin's got his hand raised.
Yeah. Hey,
He could
Justin.
probably
I
speak to it better than I can.
cannot see anybody's hand raised. My daughter's killing me.
No,
Justin, help me out here, brother.
no, you're fine. So that's correct. We have the eligibility system is not perfect, and the eligibility is not my division, but any time that and unfortunately this happens when you have a Medicaid eligibility system, anytime that you see an individual that's eligible for Medicaid, on the day that you see them, you're going to get paid. Who that payment comes from may change. And so again, the reasoning, I don't know exactly why the system determines why that eligibility changes for individuals, but unfortunately it does. We've worked on that issue. We've got it, I think, a little better as far as time frame goes. Hopefully you don't see those long 6-month drawbacks, and hopefully it's more 2 to 3 months now. And I think we're still working on that process, but some of the things that we've done to kind of mitigate those issues is that whatever the Medicaid coverage that it switches to, we've tried to stress to our MCO partners, and we do, of course, there at Kentucky Medicaid too. We make sure that we look at everything for timely filing, any timely filing issues that come along with that when you refile that claim. So that we can override that. We always make sure we work with the provider on whatever those cases may be to make sure that they receive payment. So unfortunately, that is the case with Medicaid and some of the eligibility issues, that an individual may show up. Just for instance, say they show up, they have well care, since Stuart spoke earlier, and then later well care recoups the money for that individual member. And so then when they go back on and look, it shows now that they have traditional fee-for-service Medicaid, so that they would have to rebill that fee-for-service Medicaid. Our future system, what we're trying to do is anytime that recoupment takes place, to be able to cause kind of a chain reaction where it automatically reprocesses through whatever new system. That's going to be difficult to do, but we're working on it. But in the meantime, what we can do is offer any support and technical assistance that if you have that happen, to reach out to make sure that you all are paid. And you're never going to get recouped for that instance and then not get paid, right? It's not like we're saying they're not eligible now, we're taking the money back. It's just got to come through a different source.
Ashima, does this help you at all, or do you have a contact or a way to work with DMS to? I mean, I'm not talking about you per se. I know I'm using you as an example, but you represent a group of people that we want to address. And is there a way to work with DMS to understand that you can rebuild that in a different way?
Yeah, I mean, so this is for this is for a small private practice that I manage myself for just inpatient consults. So I do my own billing. And by doing this, I've learned a lot about insurances and things like that. So like for me, for example, now I have to put in so many more hours to refile those claims that and that if I was hiring someone to do that, it's just such a waste of money, for me to have to pay someone. Now I need personally to get additional training, which I have to pay for, to learn how to do all that. So it's just so time consuming. And I wish there was just a better way that, I take the time to check eligibility, and I just feel like that's just like these are major companies. These mistakes should not be happening. And can that MCO just get the recoupment from Kentucky Medicaid instead of coming back to me? But I mean, I know that's not going to happen. But it's just it just needs to be more streamlined. It's for me, a small practice. We're not talking about like millions of dollars, but for other practices, it's just so time consuming. So I know I'm just venting, but I know that probably nothing's going to be able to change.
No, I appreciate that, Dr. Gupta. But that is a concern that we've had, and we actually have multiple facets that we're looking at the best way to do that, whether it would be to have some kind of system where the MCOs reimburse, and it becomes a little bit more of a problem when it's MCO to MCO, rather than MCO to fee for service or fee for service to MCO. But we're working on that. We're attacking that multiple heads. So we're looking at it through the systems perspective, and we're also looking at it through maybe agreements perspective. But I do appreciate the fact that you brought that up. We realize that, and it is an inefficiency in our system, and we are actively working to try to make that better and fix that.
I'd say we really appreciate that. That would be something you all could do that we could never accomplish. So I would say to those guys and under part of your team, I'd say thank you a lot. Let's turn it around here. There's a subset of this recoupment in behavioral health. Cody, can you help us, you and Dr. Lyden, help us with this, understand this query?
Yeah, not something to have to spend a great deal of time on. Just wanted to mention regarding behavioral health, the Consumer Advocacy TAC chair, Dr. Schuster, had asked the Physicians TAC to poll physicians on Medicaid audits happening in behavioral health. And so we went through KMA and we reached out to a number of psychiatrists, and the feedback was varied. Some were aware of audits that had been happening. Some had experienced audits with their practice. Others hadn't. But for the ones that had, they said there had been an uptick in audits. They cited that there had been an increase in the number of records requested, and the records requested had been more extensive, sometimes going back to up to a year. And one group in particular said they were having issues specifically with labs. The audits were looking for documentation of medical necessity and seeking to ensure that each lab has some effect on medical decision making. And that's by and large the extent to which psychiatrists told me that they were experiencing an uptick in audits. And again, that's in response to the conversation that the MAC had at their previous meeting where Dr. Schuster asked various members to poll some of their groups.
Well, firstly, thank Dr. Schuster for pitching this our way. Send him our compliments, and please let him know that we've brought this forward to address. Eric, can you give us some insight into this, please?
No, well, I checked with my office staff. We don't have any, we may have had some audits, but nothing that we've noticed. Some of the people I work with, I haven't had a chance to check with. So
Okay.
I don't have any new insight to it. I know we do get pushback from time to time on labs, and labs being ordered and labs calling us and going, hey, there's no medical necessity for this. And I got somebody with bipolar disorder that I have on lithium, and they question why I'm getting a BMP and a lithium level. It's like, well, you got your blood levels. I got to make sure I'm not killing their kidneys. It's routine standard practice of care, and they're saying the labs are being no medical necessity. And it's like, then who do you fight? Do I go back to the person at LabCorp or Quest? I mean, it's just labs, and justifying labs can be difficult. That's where I've run into some problems.
Well, on the face of it, not knowing any more than I know, there's a couple of ways my mind wants to break this argument down. First, I think we alluded to it early in our conversation together, where you have what I would call the healthcare professionals, particularly your physicians, your psychiatrists, with their training, their experience, they have one way to look at the world. Then you have these people that are kind of physician extenders they look at the world sometimes a little differently, and their experience is not as robust. I could see that being an issue. Another one that concerns me is, I don't know if how many of our colleagues know about here in the last few months, there's been a move forward to move some of these Alzheimer's type demential labs. I have an idea that these are very expensive. And my concern is, are they being used adequately? For example, you can, if you pay for these labs to see, well, does somebody have Alzheimer's based on some lab report? Is it really necessary to get do we need that, or can we make the diagnosis? Is it going to, I only order labs when it's going to change what I'm doing, or if it's part of the monitoring system that we can generally agree on is something we need to monitor, like a lithium and some renal function studies. So when I break it down, that's the kind of thing that I'm looking at. Daryl, do you have some thoughts here?
Dr. Thornberry, someone has their hand raised.
I do. I thought it was Mr. Van Cleve.
Yeah, it's Chirag. Sorry about that. Yeah, in the spirit of, we all want the same thing, and transparency and trying to get to the right place. Yeah, I would say that BH audits are probably up. I'm not saying that we're doing it, but I do know that they're up. And why are they up? Because, as Stuart has alluded to in multiple TAC meetings over the last several, feels like years, but it's probably months, that there is a cottage industry of advanced practitioners and non-clinical folks just driving up utilization. And so for us to make sure that, the people who we're stewards for are getting the right care at the right cost, we're doing audits. We, meaning the collective we of MCOs across the country and the universe.
Yeah, I understand that. Cody, do you have any thoughts on this, or do you have any more information for us?
That was all I had on that.
Yeah, well, I certainly see their perspective, and I think this is one of those things that, well, it's not. I can't live in the world that I wish I could live in. I live in the world that I live in, and so I think when we saw some of these physician extenders become independent, I think if you work in an ER, if you work like in a hospital-based system where you see people come in for admission, if you work, I'm sure for the MCOs and you see quality of care, there are just discrepancies there, and I don't want to push that button too hard. So I certainly see their point of view on it. I don't think that auditing people is, for for negative reinforcement is the right thing to do. I think, if we're trying to get to a shared position where we're trying to promote appropriate testing and monitoring for appropriate conditions as a way to remove those 3% of people that aren't doing the things that they should be doing, or to help educate people that need better education. I understand that. It's hard to push back on that, and I don't think I would want to. Does anybody have anything else on the subject?
I would just add, from our KMA perspective, I don't know that we've had any direct outreach, at least that hasn't come through me, regarding issues in this space. It is more so because I polled those groups that I heard about it. But certainly we'll continue to listen, and if we do get any more feedback, we can circle back on it.
Okay. We have a little time. I try to get us out a little early. I can't always be successful at that, but in respect of everybody's time, we have a little time for open discussion. Is there a concern that should be brought forward today, or something that we can look into and bring to our agenda the next time we meet? I'd open the floor for all of our MCO partners, for DMS, or for any of my colleagues here. Okay, well, I don't think we have any recommendations today. We have Cody, do you have or Kelly, do you know about when the next meeting would be kind of penciled in for the end of the year?
I don't believe there is another meeting scheduled for the end of the year.
Okay.
We are currently working on scheduling all 17 TAC meetings and the MAC meeting for the year 2025. We hope to have those out by the end of the month. That we do appreciate your patience. As you can imagine, that does take some time to get worked out with our Zoom account, but we are working on that, and we'll get that out as soon as we can.
Well, Kelly, I don't envy you the headache that you have. Again, with our partners and our colleagues, I try to only bring meetings together when we have something to work on together. We don't have meetings just to have meetings. I would be extremely complimentary of all of the members here today. I thought this is the best meeting we've had. I think it's the best meeting we've had in a couple of years. And again, it's a better tone to work together. And that's what it's easy. I have a 2-year-old child that can knock down blocks. It's very hard to build the energy to sustain a project or an initiative to work together to solve problems, which is, I think, what we all want to do here. And that's the intention of the committee, so long as I'm on the committee and for the presiding officer. Thank you, everybody, for being here today. Dr. Terry, it's great to talk to you, as always. If there's no other business, I would adjourn the meeting. Thank you, everybody, and we'll see you next year.
Thank you. Everybody have a great weekend.
Bye-bye.